Thanks very much. It's a great pleasure to be here. My name's Sharon, Lewin. I'm speaking to you from Melbourne, Australia. And today I'll talk to you about Hiv Hpv Co-Infection, give you a short update on pathogenesis, natural history, and treatment. So, HIV, particularly in the Asia-Pacific region, remains a major problem, with about 5.9 million people infected with HIV in this part of the world. In addition, we know that hepatitis B is extremely common in the Asia-Pacific region. Estimated number of people living with HPV, 266 million. And from many different studies, we now know that of people living with HIV, between 5 to 20% are co-infected with hepatitis B, and particularly of high significance in this region. So today I'll speak to you about HIV Hpv co-infection, a bit about epidemiology, pathogenesis and treatment. I'll talk about the impact of HPV active antiretroviral therapy on two markers of response to hepatitis B treatment, particularly loss of Hep B surface antigen and liver disease progression. And finally, I'll talk a little bit about strategies for a hepatitis B cure in HIV Hpv co-infection, what's being evaluated currently, and what issues need to be considered. So HIV Hpv co-infection, we've known for a very long time that HIV infection has a significant impact on the natural history of chronic HPV infection compared to people that are infected with HPV alone. And this is characterised by increased levels of HPV DNA, accelerated progression of liver disease, and increased liver-associated mortality. And these studies were, of course, done many years ago before the availability of HPV active ART. HPV active ART means antiretroviral therapy that contains both TDF or TAF together with 3TC or FDC and is initiated at the time of diagnosis, i.e. any CD4 count and any level of liver inflammation or any ALT. And now, despite the effect of HPV active ART, we know that life expectancy of co-infected individuals still remains reduced compared to people with HIV alone, and we also know there is still progression of liver disease. So there is room for improvement of how we manage people living with HIV and hepatitis B co-infection. So it's important to understand pathogenesis because that will give us clues into additional treatments that could be followed. And this is a slightly complicated diagram, but it shows the liver up here, how the liver interacts with the blood circulation and how the liver interacts with the gastrointestinal tract, because all are probably important in driving pathogenesis of liver disease. And work we did previously and summarised in this publication from last year has shown that HIV can actually infect multiple cells in the liver, and this probably has a role in driving pathogenesis. The virus can infect hepatocytes, it can infect Kupffer cells, macrophages that sit in the liver, hepatic stellate cells, the cells that are responsible for liver fibrosis, and of course HIV can infect cells, infiltrating T cells or T cells that traffic into the liver from the bloodstream. We also know that HIV infection causes CD4 T cell depletion in the gastrointestinal tract. This can lead to microbial translocation as measured by increases in circulating levels of lipopolysaccharide or LPS. And LPS itself can activate hepatocytes, activate Kupffer cells, and activate hepatic stellate cells. So this combination of direct infection and alteration to the gastrointestinal tract are both very important drivers for heightened activation within the liver. And we showed recently that in HPV co-infected individuals that liver fibrosis, this is in the absence of treatment, was associated with intrahepatic CXCL10, so expression of a cytokine CXCL10, which is responsible for dragging in T cells into the liver. The number of T cells in the liver and how much virus was in the liver were all related to the degree of liver fibrosis. And we think that these studies can give us some clues into new interventions that could potentially reduce liver fibrosis. So, of course, people all receive HPV active ART, and many of these parameters will change once you start treatment. We also know that HIV and hepatitis B can directly interact with each other. So HIV infects hepatocytes and therefore can alter hepatitis B replication. This is work that we've done using in vitro models of hepatocyte cell lines. Here, the cell line's called AD38, which is chronically infected with hepatitis B. And we infected that cell line with HIV, which is modified so that it can infect the hepatocyte by expressing something called vesicular stomatitis virus G protein. We did this in the presence and absence of an antiviral drug, the presence of valtegravir, presence of efavirenz. And the black marks here is just showing you how many HBV proteins are being expressed, and they're different size HBV proteins. I think what you can clearly see here is that the HBV proteins significantly increase in the presence of HIV infection, and that's reduced if you have an antiviral on board. We've also actually specifically looked at whether all that increase is in the infected cell itself, and we're able to do this by marking the HIV infected cells with the fluorescent protein here, the green fluorescent protein, and we sorted cells to green fluorescent protein positive and negative. Again, you can see that the hepatitis B proteins are highly increased in expression in the HIV infected cells compared to the HIV uninfected cells. And finally, we show that this is not just unique to the cell line, but in fact happens in a primary cell model of HBV infection. Again, showing here that we took these cells, Hep G2 and TCP, infected with hepatitis B, could measure hepatitis B proteins, infected with HIV, couldn't see Hep B proteins, but in the presence of both viruses, a dramatic increase in hepatitis B proteins. And this is confirmed again here using different sorts of imaging where we've labelled HIV with green fluorescent proteins. You can see the green fluorescent protein here in the HIV infected cells. We labelled hepatitis B proteins in red, and you can see hepatitis B proteins expressed. And then when we put them together and infected with both hepatitis B and HIV, you can see that there's expression of both hepatitis B proteins and HIV proteins in the same cell. So we think this direct interaction between the two viruses is also very important because it alters the replication of hepatitis B. Finally, we've been interested to know whether HIV DNA can actually persist in the liver even after antiretroviral therapy. And in this study, we recruited HIV Hpv co-infected participants prior to antiretroviral therapy and following antiretroviral therapy, and recruitment was all done in Bangkok, Thailand by a collaborator, Anshali Avahingsanon. And then we measured how much HIV DNA and HIV RNA were in these liver biopsies. And we could detect HIV DNA in 83% of liver biopsies and HIV RNA in 67% of liver biopsies prior to antiretroviral therapy, which is no surprise. And that's just shown here using a particular type of a staining here for HIV RNA. And you can see very clearly that the HIV RNA here is stained in red and HIV DNA stained here in brown. When we looked on antiretroviral therapy, we could indeed still detect HIV DNA in almost 40% of the participants using PCR, but we also used this other fluorescent marker to detect whether HIV DNA was present, and you can see here that viral DNA is shown here in red, CD4 cells are shown in green, and you can clearly see here there is detectable HIV DNA even in people on antiretroviral therapy. But interestingly, no HIV RNA, suggesting that viral replication gets shut down in the liver, but there are persistent infected cells. And most likely, by basis of co-location, we think that this HIV DNA is probably infiltrating CD4 positive T cells, and this persists on antiretroviral therapy, just like HIV DNA will persist in blood. So what about treatment for HIV Hpv co-infection? Not a lot's changed here, but I'll just review the current recommendations for treatment of people co-infected with both viruses. First of all people living with HIV Hpv co-infection should receive antiretroviral therapy at the time of diagnosis, and that should include either TDF or TAF, unless there's a history of tenofovir intolerance. Stopping anti-HBV active ART should be avoided in people with HIV Hpv co-infection because of the risk of severe hepatitis flares and decompensation following HBV reactivation. If TDF or TAF can't be used, then entecavir should be prescribed and you shouldn't rely on 3TC alone. And that entecavir can be used in people living with HIV with no prior 3TC exposure and can be used together with fully active antiretroviral therapy. People living with HIV with liver cirrhosis and low CD4 counts require careful surveillance, firstly in the first few months after starting ART, in order not to overlook immunoconstitution syndrome, which can lead to a hepatic flare and liver decompensations and increase in liver enzymes. And finally, given that a lot of people are simplifying ART currently, say going from 3 drugs to 2 drugs, you have to be really careful here that if you're going to simplify with a regimen without TDF or TAF, you must always check the HBV status before doing this to check that the person is not infected with hepatitis B, it doesn't have Hep B surface antigen, then is not at risk of flare. And these recommendations come from the latest European AIDS guidelines. What about the treatment goals and monitoring for people with co-infection? Well, the optimal duration for nucleoside or nucleotide analogues with anti-HBV activity hasn't really been determined, and currently expert recommendations continue lifelong treatment and not to attempt to stop anti-HBV drugs. If the nucleoside backbone does need changing, you can stop anti-HBV therapy after you've confirmed Hep B surface antigen seroconversion, but avoid doing this in the presence of cirrhosis. Monitoring usually involves liver tests performed every 3 months during the first year and every 6 to 12 months thereafter in people on HBV active ART. HBV DNA should be determined every 3 to 6 months during the first year to ensure control of viral replication, and then every 12 months. And hepatitis B surface antigen should also be checked every 12 months until there's loss of surface antigen. And finally, people living with HIV who are HBs antigen negative but have a history of prior hepatitis B infection, so they have antibodies to core antigen, and if they're undergoing immunosuppression, the recommendation is treatment with TDF or TAF, dependent on the severity of immunosuppression. For example, chemotherapy, solid organ transplants, or B-cell depleting agents all warrant treatment with TDF or TAF. There's milder immunosuppression, such as using an anti-TNF-alpha antibody. Close monitoring is recommended. So what happens once people go on to of our Hep B active ART, and what's the impact on surface antigen loss and liver disease progression? Well, there have been multiple studies that have looked at surface antigen loss following HBV active ART. And this just shows you the different studies, and the columns summarise the duration, the incidence of HBs antigen loss, and the line indicates the median duration of follow-up. So you can see that the follow-up of these studies range between 30 and 90 months, and you can see that the frequency of Hep B surface antigen loss does vary, but can be as high as 14% or along the more common levels of 2%, similar to what you see in Hep B monoinfection. Now, we have done a study on hepatitis B surface antigen loss in a large Australian Thai cohort where we recruited 92 participants who had Hiv Hpv Co-Infection. They're enrolled in Bangkok, Sydney and Melbourne, and we looked for loss of HB surface antigen over time on HBV active ART. These participants were reviewed every 6 months for 2 years and then annually for 5 years. The mean age was 42, most were male, and CD4 count at enrolment was 500 cells per microliter. And we actually observed that the loss of Hep B surface antigen was high, about 12% of the total study entry cohort, or 15% in people that were followed up for 5 years, which included 72 participants. Now, this is far higher than the average loss of Hep B surface antigen in Hep B monoinfection, which is usually 1 to 2% per year. And therefore, this means that people with Hiv Hpv co-infection might be ideally placed to study HPV cure interventions. What about liver disease progression? Well, in a separate study, we enrolled participants. This was done entirely in Thailand prior to receiving HBV active ART. we involved participants who had been on HBV active ART for at least 12 months. They had to have evidence of suppression of both viruses with HIV RNA less than 50 copies per mil and HBV DNA less than 357 international units per mil, and we excluded anyone that also had hepatitis C infection. We did fibroscan analyses every 12 months and ranked the liver stiffness based on the definitions of METAVIR staging F1 to F4 based on liver stiffness measurements by transient elastography. And prior publications have clearly shown that liver fibrosis and transient elastography are quite different in people who have HIV Hpv co-infection or HBV monoinfection. And then we measured a range of different markers, CD4 positive T cells, viral load, a range of cytokines and markers of inflammation. And this is the cohort. We enrolled 67 participants, half in Australia and half in Thailand. Most of them were male. About 30% were E antigen positive, and really most of the cohort had very mild liver disease, with over 70, close to 87% having only F1 or F2 evidence of liver fibrosis. And we classified whether people were non-progressors, and show this on the left, or progressors shown on the right, defined by a change in METAVIR score, which was an increase which we observed occurred actually in 20% of participants. And then they then asked what were the features of these progressors that distinguished progressors from non-progressors, meaning people they all came in on stable ART. Why did some people progress and others not? We measured a large number of different parameters, but these are the ones that were significant. So in red, you're seeing the progressors, in grey, you're seeing non-progressors. And you can see that progressors had a significantly lower native CD4 count, a significantly lower baseline CD4 count, meaning their CD4 count at enrolment, and significantly higher levels of a circulating molecule called HMGB1, or high mobility group box 1, which is the marker of apoptotic cells. And this may well be a predictor for people at higher risk of liver disease progression. Finally, in the last few minutes, I'm going to just quickly talk about strategies that have been tested for an HBV cure, specifically in Hiv Hpv Co-Infection. So what do we mean by an HBV cure? Well, it means that people have a finite period of therapy, say 1 to 2 years, that will achieve HBs antigen loss. The current focus of HBV cure strategies is people with chronic HBV infection who are on antivirals, and this currently includes people with E antigen positive or E antigen negative chronic hepatitis. Now, the other individuals in Hep B monoinfection, such as those who are E antigen positive or E antigen negative but no evidence of hepatitis, these people also receive antivirals in Hiv Hpv co-infection. So therefore, when we're looking at cure, we're looking at a much bigger number when we're looking to see about achieving an HBV cure, we're looking at a much bigger number of people with Hiv Hpv co-infection. What are some of the strategies? Well, they're largely aimed at either reducing the amount of virus in the liver, HBV DNA, surface antigen, or the long-lived forms of cccDNA, alternatively enhancing immune control of hepatitis B. And I'm just going to talk about these strategies because they're quite relevant to strategies being used in actually HIV cure. So one approach that's being currently tested is selgantolimod. Selgantolimod is a TLR8 agonist with the potential to induce intrahepatic antiviral immunity. Selgantolimod or TLR8 agonists activate intrahepatic myeloid cells. They inhibit immunosuppressive cells. They alter the migration, priming, activation, and proliferation of T cells. And at least in Hep B monoinfection, they're shown to have a favourable impact. So this is a study that comes from a combination of 2 cohorts of people with chronic HBV infection, one viremic and the other aviremic, who were randomised to receive a nucleoside plus placebo, or a nucleoside plus the TLR8 agonist GS9688 at 1.5 or 3 milligrams for 25 weeks, and then everyone was placed on antiviral drugs. And you can see here that this TLR8 agonist does indeed stimulate the immune system when you look at the production, for example, here of IL-1, I'm just showing you, with placebo in grey, 1.5 milligram dose in green, or 3 milligram dose in blue. And after each dose, you can see a significant increase in this particular cytokine. Now, the markers of Hep B cure is a loss in hepatitis B surface antigen. So these waterfall plots show you the changes in hepatitis B surface antigen of all the participants in the study who either received 3 milligrams of the agonist in blue or 1.5 milligrams of the agonist in green. And in the darker colours, they were e-antigen positive individuals, and in the lighter colours, e-antigen negative individuals, compared to those that received placebo. And you can basically see that the number of people that had bigger S antigen losses and the frequency of people that had S antigen loss was significantly increased in the presence of the TLR8 agonist, meaning that this could be a favourable effect on reducing hepatitis B surface antigen, which is a pathway to a cure for hepatitis B. TLR8 agonists also can have a direct effect on HIV latency. So therefore, using them in co-infection could in fact have a dual effect on both hepatitis B and HIV. And this just shows some really interesting work of ex vivo, where people living with HIV on antiretroviral therapy donated their CD4 T cells, and the response to an activating stimulus ex vivo was assessed. And here you're just measuring copies per mil of HIV virus and supernatant, and you can see that in the presence of a TLR8 agonist there's a significant increase, suggesting that these drugs also reverse HIV latency. And there is now an ACTG study in development using a TLR8 agonist and its impact on hepatitis B cure in HIV Hpv co-infection. This is the design of the study. It's a safety tolerability study of the oral TLR8 agonist, sengatinib, on HBs antigen in participants with chronic Hep B and HIV co-infection. The study is enrolling 36 participants, 18 with e-antigen positive disease, 18 with e-antigen negative disease, and they're randomised to receive either placebo plus optimised antiviral backbone or selgantolimod, 3 milligrams per week for 24 weeks. And then at the end of 24 weeks, everyone moves to the optimised antiviral backbone or HPV active ART. It's weekly oral dosing. These participants will join from the United States, Africa, South America, India and Thailand. And the primary endpoint of this study is for participants with more than 1 log decline in HBs antigen. Finally, anti-PD-1 is another intervention that's being actively pursued for an hepatitis B cure. Anti-PD-1 boosts the immune response to PD-1. The first study actually of anti-PD-1 outside of a cancer setting was in the presence of hepatitis B monoinfection. And here, again, the study is assessing hepatitis B surface antigen change from baseline. This is a waterfall plot. These are participants with chronic hepatitis B on entecavir with suppressed viral load, and they received a single low dose of nivolumab, either 0.1 or 0.3 milligrams, with or without an HPV vaccine. Shown here in red is anti-PD-1 alone, in blue is anti-PD-1 with the vaccine, and you can again see that you've got quite significant declines in HBs antigen with anti-PD-1 alone. And one individual had a significant flare with HBs antigen seroconversion. And what was really interesting in this study was that very high receptor occupancy of PD-1 was achieved with just a single low dose of anti-PD-1. And that's shown here. A single low dose of anti-PD-1 gave 80% occupancy, which lasted for 6 weeks. There's a lot of work being done on anti-PD-1 for an HIV cure. So I think this also presents a real opportunity for new studies in HIV Hpv co-infection with this intervention. So in summary, HIV Hpv co-infection is common globally, and long-term HBV active ART is required for all people diagnosed with HIV. And I do think that we should be thinking about strategies for an Hep B cure, because this might be a really favourable population to investigate. HIV can directly impact replication of hepatitis B, leading to higher levels of surface antigen production. And given that HIV DNA persists in liver on ART, further work is needed to understand how this might affect hepatitis B persistence. People with HIV and hepatitis B co-infection have higher rates of treatment-induced hepatitis B surface antigen loss up to 15% over 5 years. In a subgroup, 20% have ongoing liver disease progression, and this is highest with people who start treatment with a low CD4 count or with high HMGB1. So a reminder that the earlier initiation of HPV active ART, the better. And finally, there are some immunotherapeutic approaches being tested at hepatitis B cure, such as TLR agonists and anti-PD-1, that can also directly impact HIV persistence, justifying investigation of these interventions in people with HIV and HPV co-infection. I'll make the point that there have been very few studies of hepatitis B cure in this population, and we need to see far greater activity here. I'd like to acknowledge all the members of my own lab, particularly those that have played a very important role in our co-infection studies, and that includes Jennifer Orsley, Kasia Singh, Wei Zhao, and Jennifer Zabato. All our work on HIV-HB co-infection is done in partnership with Anjali Avahingsama at the HivNat Thyroid Cross Centre. And I'd like to also thank our funders. Thank you very much.
Thank you, Dr. Lewin. This is a very wonderful presentation. It's certainly very clinically relevant to HIV treating physicians, as well as those of us not treating HIV, but taking care of HIV patients. There is a question from Anonymous. It says, Dear Dr. Lewin, in one of your slides, you mentioned patients who have passed hepatitis B, meaning that have hepatitis B core antibody positive, surface antigen negative, will require TDF or TAF depending on the level of immunosuppression. Would you elaborate, please? Which of these patients will need TDF, TAF? Who will not need TDF, TAF, please? And he also wanted to know how would you monitor these patients? Thank you.
A subgroup which don't officially qualify for co-infection. So when we talk about hepatitis B co-infection, we mean people that are HBs antigen positive. However, there's an emerging experience with people that have passed cleared hepatitis B, so they're Hep B surface antigen negative but core antibody positive, who undergo intensive immunosuppression, solid organ transplantation or chemotherapy, and it's in those patients in whom antivirals are recommended, and that includes TDF and TAF. In the setting of someone with HIV infection and past cleared hepatitis B, it's not such a big issue because they're going to be on antiviral therapy and most likely they will have a TAF-containing regimen. It's probably an emerging issue now that we're using Dovato or dual nucleosides that don't include TDF or TAF. And monitoring means looking at HBV DNA as well as ALT over the period of intense immunosuppression.
Thank you.